Meu nome é Guilherme Jorelli, sou médico nutrólogo, médico do esporte e sou coordenador da pós-graduação de Nutrologia do Hospital Israelita Albert Einstein e coordenador da Nutrology Academy. A minha formação inicial foi em clínica médica e endocrinologia e eu busquei a nutrologia como uma maneira de complementar o meu entendimento sobre as doenças. A sensação que eu tinha quando trabalhava principalmente com diabetes é que eu estava chegando muito tarde para poder ajudar o paciente. Então o paciente estava usando insulina já e quando você começa a entender a doença com diabetes, você vê que a insulina ela não está tratando a causa, ela já está tratando um problema avançado no paciente. Então estudar sobre nutrologia, ou seja, entender a interação do alimento com o organismo humano, abriu muito a minha maneira de enxergar a medicina e me permitiu tratar o paciente de uma forma mais preventiva. Nutrology Academy é para quem tem interesse em aprender mais sobre nutrologia. Não é necessário ser médico nutrólogo e nem querer virar médico nutrólogo. Então a gente tem vários formatos de curso, a gente tem cursos livres e gratuitos e a gente busca chamar, tanto para os cursos quanto para as lives, médicos que não só sejam muito estudiosos e tenham um grande currículo, mas que principalmente que pratiquem. O que a gente quer é que as pessoas entendam a nutrologia, entendam a obesidade, entendam o que é a suplementação e que ao entender isso, elas possam aplicar no seu dia a dia de uma forma mais ajustada para o seu paciente. O objetivo aqui é que a gente tenha interação e através da interação vão surgindo as dúvidas e o que a gente busca aqui é transformar as dúvidas em conhecimento prático para o dia a dia.
Conheci a Nutrology Academy. Foi a partir daí eu fui fazendo cursos, assistindo as lives. Com isso eu fui adquirindo segurança para poder atuar e atender meus pacientes. A cada palestrante que eu ouvia, a cada curso, a cada NutriWeek que eu participava, eu me sentia mais segura para poder usar o que eu estava aprendendo na prática clínica, ajudando não só a mim, mas os amigos e os amigos dos amigos. E aí a clientela foi crescendo e hoje em dia eu consigo trabalhar. Claro que as dúvidas sempre existem, mas a gente tenta transformar, como diz o Dr. Guilherme, as dúvidas em conhecimento.
Nas aulas eles falam, às vezes falam coisas que eu nem pensei antes. Eu falo, caramba, isso é verdade, podia acontecer. E quando eu vou ver, uma hora acontece comigo e pronto, eu já sei o que fazer. Falam mesmo o que fazem, como fazem, o que é off-label, o que não é off-label, o que está na diretriz, o que não está, se fazem ou se não fazem. É um lugar para realmente aprender, acelerar o aprendizado.
Essa discussão de casos com vocês nos traz esse fortalecimento de prescrever e fazer o uso das medicações de forma adequada.
E eu acho que assim, logo no começo eu já consegui tirar muitas dúvidas, tendo as lives. Então, foi muito importante, assim, esse apoio que realmente é um diferencial, assim. A gente realmente mandar pergunta, realmente ter uma resposta, ter uma interação, discutir caso clínico. Então, foi muito proveitoso, assim, foi muito importante para dar essa segurança. Então, é bom que tem umas aulas, né, partidas num raciocínio, mas tempos reduzidos, então você consegue... teve um intervalo maior de paciente, consegue assistir uma aula menor, depois você dá continuidade de uma outra aula, tem agendado, né, as aulas que vão ser online, então você consegue também se programar com antecedência, já sai essa programação, então a gente também me organizei para participar da aula ao vivo, né, da aula ao vivo, que também deu para tirar dúvida, e posteriormente também mandei o caso clínico para uma nova discussão.
Meu conhecimento, assim, cresceu em nível exponencial, que eu pude trocar ideias de pacientes, ideias de medicações, que às vezes eu ficava insegura, né, de estar passando. Então, através, né, dessa questão, essa interação com os preceptores, com a monitoria, ter aquela confiança, né, de mandar um WhatsApp, ter a resposta rápida, troca de artigos, isso, assim, acrescentou muito em questões de conhecimento.
E, de repente, todo aquele conhecimento que ficou acumulado do curso, começaram a surgir os pacientes e aquele conhecimento começou a ser aplicado. Assim, isso é empolgante, a gente fica querendo mais paciente, e quer aplicar tudo que a gente sabe, está aprendendo e quer saber cada vez mais, né?
A gente tem a oportunidade de discutir mensalmente casos de consultório de uma forma muito próxima, tem acesso, enfim, discuto casos reais e a gente consegue de uma forma muito bacana, muito próxima, muito prática, ter uma ajuda e dividir os casos, isso reduz, né, a nossa ansiedade, aumenta o conhecimento, é uma coisa muito bacana.
Tem um histórico de perda de peso também, lá atrás. Então eu precisava ser a médica que eu nunca tive no meu tratamento de obesidade. E a partir dali eu reencontrei o Dr. Giorelli nas redes sociais, através das lives das terças-feiras, lá eu acho que em 2020, na pandemia, e reencontrei o meu professor, Dr. Paulo, né? E ali reacendeu uma chama de realmente viver daquilo, e eu realmente fui fazendo os cursos todos, e aquilo ali me deu amparo na hora que eu mais precisei. Consegui ter umas condutas mais assertivas, né? Os tratamentos mais individualizados, tudo que eu precisava achar. Um direcionamento profissional eu achei lá no Nutrology Academy.
Vocês trazem a parte prática de uma forma muito leve, muito agradável. Isso fez com que me encorajasse a usar os medicamentos, principalmente, né? Eu, como cirurgião, assim, tem que virar a chavinha na cabeça muitas vezes, não é fácil, né? Encoraja isso, encoraja a gente a estudar, encoraja a gente a praticar um pouco mais.
Aqui não parece, é uma grande família. Então você se sente muito à vontade, né? Não tem aquela pressão de alguém querer ser melhor do que o outro. Pelo contrário, aqui as pessoas são todos humildes, todo mundo aprende com todo mundo. E você tem a segurança dos professores, né? Que praticamente seguram a sua mão e te incentivam a ser melhor, questionar.
Impedância, o passo a passo, como é que você interpreta, vocês melhoraram muito a interpretação, que não é só saber os números, assim, individualizar aquela bioimpedância para cada paciente, qual é a proposta e meta para cada paciente. Acho que isso, assim, melhorou muito na minha cabeça.
Vocês conseguem passar uma segurança muito grande para a gente, pela forma como vocês transmitem o conteúdo, sempre muito embasado, né? Nossa, vale a pena demais, realmente, participar desses encontros, tirar essas dúvidas, é uma coisa muito, muito, muito proveitosa. Eu tenho utilizado bastante as coisas que eu aprendo no meu consultório.
Mas de vivência, uma troca mais ampla. Medos, de receios, de vida mesmo pessoal, é uma troca muito rica, e o contato com os professores e o contato próximo, isso que eu acho que faz todo o diferencial. Eu saio daqui com outra cabeça, com outros pensamentos, com outra ideia e principalmente com uma rede de apoio.
O curso é rápido, fácil de assistir, é gostoso de assistir, você sente vontade de estar com vocês, encantada. Todo mundo deveria poder fazer isso, porque você é um ortopedista e você consegue tratar a sua paciente, você consegue ajudá-la a perder peso. Você é um endócrino, você é um clínico, né? Um clínico geral, não importa. E eu vi o curso como uma opção muito boa para eu conseguir focar no meu consultório, conseguir focar nos meus projetos pessoais, porque o plantão ele destrói, né? Então assim, eu quero a minha qualidade de vida e eu quero levar isso para os meus pacientes.
Boa tarde, gente. Então, dando continuidade aqui ao congresso, nós teremos agora uma palestra muito aguardada do professor convidado, Dr. Paul Wischmeier, que vai nos abrilhantar aqui com uma apresentação otimizando desfechos no paciente cirúrgico, o papel da nutrição e dos agentes anabólicos. Dr. Paul é assistente da UTI na Universidade de Duke, em North Carolina, e como a gente viu aqui em várias aulas, é autor de vários papers que a gente usa aqui no nosso dia a dia, né? Dr. Paul, it's all yours. Thank you.
Obrigado. Boa noite. I'm going to try to speak with this microphone, so bear with me if I move my hand around a little more with this in my hand. But I'm thrilled to be back in Brazil tonight and today. It's been too many years since I've been able to be here. It was sad not being able to visit during the pandemic, and I'm very happy to come back. Brazil is perhaps my favorite country in the world to visit because of all of you and how passionate you are about nutrition. So thank you for having me. So tonight, what we'll focus on talking about is the key role, the essential role of nutrition and anabolic agents in optimizing patient outcomes. And I think the key message I want all of you to take away is that no patient anywhere in the world should ever have elective surgery without having nutrition screening and optimization occur. How many of you can say that's true in your hospital now? Raise your hands. Same for mine, but we try to be better, and that's the goal, that someday no patients will ever go to surgery malnourished. Because ultimately, a major operation for our patients who have cancer or having other major surgeries is like running a marathon. And just like when you run a marathon, how many have run a marathon in this room? Raise your hands. Oh, I see some. Nice, very good. And so just like running a marathon, you have to train, you have to exercise, you have to eat right, you have to hydrate and carb load. Same as for surgery. Only for most of our surgery patients, this is their race of a lifetime. This is the marathon of their life because they are literally competing for their life. And so we have to train them the same way with nutrition, with exercise, with all of the key things that you would do to train for a marathon, we have to do for our patients as well. And of course, it's not the marathon of the road, it's the marathon of the table, the operating room table. And so what happens to our patients, which is all too common, sadly, when they try to run this marathon without training? And to do that, I want to tell you a story about a patient that I cared for some years ago. And his name was Joshua. And he was a 23-year-old back when I lived and worked in Colorado in the US, who had Crohn's disease. He was coming for an elective colectomy. And of course, he came to the pre-op clinic just 2 days before his surgery. So we had very little time to optimize him. And his BMI was 18. He'd had a 20 kilo, forgive the pounds, 20 kilo weight loss in the past 3 months. Is he ready for surgery? Who thinks he's ready? Raise your hand. Should he have surgery tomorrow? Yeah, no. But he did. He went to surgery, sadly, and this is all too common. And he did okay for the first 3 days after surgery. Remember, he's young. But unfortunately, on the third day, he developed a cough and a fever, and he was diagnosed with pneumonia and put on antibiotics. But Joshua's disease progressed to septic shock and started to bleed into his abdomen. He got DIC, and he was in a small hospital, being cared for in a small hospital, and they didn't feel they could care for Joshua anymore. So they flew him to us at the university to care for him. And we took him to the operating room. We relieved the clot, and he came back to the ICU, which is where I met him for the first time. He came back with an open abdomen, an ARDS from the shock. He was very, very critically ill at this point. And he went through all the things our critically ill patients after surgery go through, including, sadly, poor nutrition, both before and after surgery. And of course, despite all those things, so we know what that looks like, right? He didn't have a pre-op nutrition assessment. He didn't get the pre-op nutrition or immunonutrition he needed. And then, of course, after surgery, the surgeons wanted to wait for bowel sounds. Who thinks bowel sounds are important in feeding? Good, no one raised their hand. Good. So, but he stayed in PO for 5 days. And of course, we know it's not the surgeon that causes ileus, it's the lack of feeding to the stomach for a day or more that causes ileus. I used to work in the burn unit. And we fed our burn patients immediately on admission. And if we fed them, we could feed them for a month. But if you wait a day, their stomach stops working because of the stress, not because of the surgeon. And that's what happened to Joshua. And so he vomited and had an ileus. He tolerated about half his feeds because it takes an act of God to start tube feedings in surgery patients and the nurse going to lunch to stop them. And so we got about half of what he needed. Despite all of this, Joshua left the ICU 48 days later. Not to go home, of course, but to go to rehabilitation. He was too weak to go home. And so we as the physicians, most of us, applauded. He must be better, right? He's leaving the hospital. Was he a success? I asked Joshua what he thought about his state of life the day he left the ICU, and this is what he told me. He said, "I'm glad I'm leaving the hospital, but I can't feed myself or swallow. I'm too weak. I have to learn how to swallow again because of my weakness. I have to be fed by a tube. And I can't stand, walk, or dress myself because I'm too weak to get out of bed. I'm too weak." But none of those were his number one complaint. His number one complaint was this: "I can't even change the television remote because my hands are too weak. My hands are too weak to do that." So Joshua goes to rehabilitation, and I get a phone call from his father 1 month later, and I'm anxious to hear how Joshua's doing. And his father calls me and says, Joshua was doing his walking and exercises in the hallway yesterday when suddenly he didn't feel very well, and he had a feeling of doom, and his chest began to hurt as he walked down the hallway of the rehab center. And moments later, Joshua fell to the floor in the hallway in cardiac arrest. Remember, he's 21 years old. He got CPR for 40 minutes in the hallway of the rehab center in front of his father. Remember, he's 21. And moments later, Joshua was declared dead. What did he die of? You can guess. He died of a pulmonary embolism from immobility. He got a blood clot and wasn't recognized. He was 21. His dad was in tears as he told me the story. What did Joshua die of? What actually happened here? We treated his sepsis, we cured his IBD, we treated all of his illnesses. He left the hospital. He should have lived, right? He was 21 years old. What did he die of? He died of this: malnutrition, sarcopenia, right in front of me. I'll never forget it. And I swore to never let it happen again if I could. So nutrition was neglected in this patient, and it was an emergency, just as important as any other system that we care for in the ICU or in the hospital, as important as infectious disease and respiratory and cardiac. We treated all those things. He died anyway. And so we have to be better than this. We have to do better for our patients, but how can we do that? And so one of the ways in surgery, of course, we've tried to do that is ERAS, Enhanced Recovery After Surgery Programs. How many of you do ERAS in your hospitals? Raise your hand. A few. Okay, that's good. So ERAS is awesome. And for those of you who perhaps are hearing about ERAS for the first time, I'm going to let somebody who does awesome better than me tell you about it. Listen closely. Oh, I need volume. Here we go.
One, go. Have you the news? Everyone's talking. Close up the goods. Everyone's walking. An operation where coverage fast and limited parts like a master. I realize ERAS and passing gas. So being on food, now easily fast. 2 days later, being a forecast, feeling like a cost. ERAS is awesome. Stepped on my bed, grabbed my skateboard, tossed in the mood. Awesome food. Awesome food.
So of course, ERAS is really awesome. And there's many parts of ERAS, but nutrition plays a key role in every part of enhanced recovery programs. Across the board, nutrition is essential. And one would think that nutrition is probably the easiest part of it compared to trying to do epidural anesthesia and balance fluids perfectly in the operating room. This should be easy, right? And all our patients should be getting very well fed. This is my youngest son when he was 3. He's very well fed. But my patients, not so much, right? We're not very good at even diagnosing malnutrition, much less treating it. And so again, we have to be better. And so in order to try to be better, I was honored to work with a group of surgeons and anesthesiologists and dietitians and experts from around the world on guidelines, nutrition guidelines for surgery. And these were published a few years ago. And we tried to come up with consensus, simple to use guidelines. And this was the summary. These are some of the key things we came away from. The first is that many patients, especially having gastrointestinal surgery like Joshua, are malnourished. So 2 out of every 3 patients, most of the patients you'll see coming for gastrointestinal surgery electively are malnourished by definition. If you are malnourished, you're 5 times as likely to die after surgery. 5 times as likely. And again, this is easy to treat, but we don't do it. And you're likely to have complications. But only 1 in 5 hospitals, we did a survey of the big university hospitals in the US, of the GI surgery programs, and we asked them, how many of you routinely screen for malnutrition? Only 1 in 5 screen. But we asked all the surgeons that same question, how important is nutrition? And all the surgeons said, oh, nutrition is very important. And if we treated it better, my patients would do better. And we found that every dollar that you spend on the oral nutrition supplements, the little drinks, saves $52 in hospital costs. The unfortunate part is only 1 in 5 malnourished patients ever get treated with these easy-to-use supplements, these easy-to-use therapies, really. And so we tried to make this easy. And these are our 6 recommendations to do pre-op and peri-op nutrition better. The first is nutrition screening is essential. Nutrition screening is essential, right? Protein delivery is more important than calories, so emphasize that to your patients. Again, we have to minimize the MPO period and restart feeding the day of surgery, very important. Oral nutrition supplements should be essential for all patients, malnourished or not, after surgery, because we know our patients don't eat enough. Clearly oral before intral, before parenteral, but parenteral is important. And this is a team sport. We need everyone on the surgical team to be part of it. The nurses, the physicians, the surgeons, the anesthesiologists, everybody has to be part of it. And so to talk about how we might use these recommendations that we made, I'm going to tell you about another patient. This is a patient I took care of just 2 years ago now, I guess it is, at Duke, where I work now. And his name was Elijah. He was an 89-year-old coming for colectomy. He had rectal cancer, and he had some COPD. And he'd been losing weight. He'd lost about 10 kilos over the last 3 months because of this obstructing mass he had in his rectum. And he's telling me, I'm very active, but I'm feeling weaker than I used to feel. I feel less strong. But I'm pretty active for my age. He was up on the roof of his church fixing the roof the day before surgery. This is a very active elderly man. So question 1, is he ready for surgery tomorrow? Not so much, right, with his weight loss. He's lost weight, he has low BMI, low albumin. Albumin's not the perfect nutrition marker, but it's a very good risk marker in surgery. So how should we assess nutrition? And in our guidelines, we developed a score called the PONS score, which brings in parts of the NRS and other scores to try to make a surgical specific nutrition risk score. And we validated this score. When we originally made this score, we cut the albumin at 3, but we did a large validation set at Duke, and we found that 3.5 was a better predictor of risk of adverse outcomes. And so low BMI, loss of weight, poor intake, low albumin, questions you guys all know. If any of these are positive, you get referred to a dietitian that the hospital pays for to see these patients by telehealth. So they interact and they get recommended nutrition supplements. And this is what our screening pathway and our surgery pathway looks like at Duke. If you don't have nutrition risk, if you're well nourished, like hopefully most of you in the room, you still get immunonutrition for 7 days. Everybody should get that. If you have surgery tomorrow, you all should take it. And then a carb load the night before in the morning of surgery. And then we give you immunonutrition for a week and a high protein H&B containing oral nutrition supplement for a month. If you're high nutrition risk, you get referred to the dietitian clinic. You get high protein oral nutrition supplements for 1 to 4 weeks with H&B. You get immunonutrition for a week, a pre-op carb load, and then you get immunonutrition for another week and a month of H&B high protein oral nutrition supplement or a high protein oral nutrition supplement, depending on what you have available. And then our dietitian calls you each week to monitor and to help counsel the patient and to follow for compliance. So of course, this patient, Elijah, is at very high risk. He's a very high risk patient. He has a very, very significant risk of surgery. Now, what about the obese patient? What's the future of nutrition assessment? These questions are very subjective. The future is CT scan and ultrasound-based lean body mass for risk prediction, right? We know that lean body mass on the CT scans that all of our patients get anyway is very, very good predictor of surgical complications and other adverse outcomes. And it shows, for instance, in pancreatic cancer, that your mortality is much higher if you have a low muscle mass on CT. Now, I will tell you, the software to do this, the Slice-O-Matic software, is free. And there's a radiologist at Harvard in the US that is reading out lean body mass on every CT scan. He's getting our Medicare, our government insurance, to pay for it. So we're all trying to learn how to do that. This may be a standard of care soon. And so we think this is the future. You can also do this with an ultrasound in the clinic. A lot of our dietitians are using ultrasound now to do this. And so again, it's also part of the GLIM criteria. Muscle mass needs to be an essential part of our future in nutrology and in nutrition care. So whether it be by CT scan or by ultrasound, this needs to be something we all learn to do. So how should we treat, now that we know Elijah's malnourished, how should we treat it? So again, we recommend all patients coming to surgery should get 1.2 grams per kilo per day minimum before surgery to optimize them for their surgical procedure. And of course, we know this is critical because we know when the body's stressed, whether it's the car that hits you, the tiger that bites you, or the surgeon that hits you, our body breaks down muscle to generate amino acids, to generate glucose to run away from the tiger or run away from the surgeon, and to also fuel our immune system. So we don't need a lot of extra glucose calories, and most of America is obese, so they have enough glucose calories. But we do need protein because this is something that begins to happen immediately. And it can last for up to 4 weeks following colorectal surgery, this catabolism. And I've always thought that patients after big surgeries in ICU had to lose weight, but I'm going to show you that isn't necessarily true. That maybe if we do things right, they don't have to lose weight and muscle. But again, they can't regain or maintain their muscle mass without protein. You can't build a house without bricks. You can't maintain muscle or rebuild muscle without protein. It's fundamental. And so again, these are what our goals for our societal guidelines read, 2 grams per kilo in some cases, in most cases. And of course, the other part is we're operating on older and older patients. Elijah's almost 90 years old. And so again, anabolic resistance becomes very important. And that's the concept that as you get older, it takes more grams of protein to build the same amount of muscle as it did when you were younger. Now, not all older people lose muscle. This guy's 70 years old. He looks pretty good. He does more than just eat right, i.e. anabolic interventions, steroids we'll talk about, to look like this. But maybe our patients need to do this too. And we can learn a lot from athletes, right? Athletes take in protein throughout the day. They take in things like H&B and leucine to stimulate pathways, and they always take in protein before they go to bed. There's wonderful data. All your patients who are at risk for malnutrition should be taking in a protein shake or a protein ONS the night right before they go to sleep, because that's when you build muscle the best. And of course, exercise is essential here, because the catabolism and anabolic resistance of surgery and critical care is much more severe. And so protein and nutrition alone are not going to combat that, right? We're going to need other things like H&B, like oxandrolone, like anti-catabolics, like propranolol. We'll come back to that. Because the reality is, of course, we know in an ICU patient, like Joshua was, 60 to 80% of people on a ventilator for more than 5 days will have weakness that goes on for years. Some of it never goes away. Even major surgical patients have significant disabilities in almost half the patients that have surgery, especially elderly patients. So this is a big problem. And so again, we recommend all these patients who are having major surgery get a high protein or nutrition supplement because they're never going to eat enough protein to get themselves ready for surgery. And there's a lot of data for this. This is just one trial, 800 gastric cancer patients. Half of them got pre-op nutrition for 10 days, half of them didn't. Significant reductions in infections and surgical site infections from just 10 days of this intervention. So 7 to 10 days is enough. You don't need weeks and weeks. Again, not everyone can take in enough or can eat at all. If you have an obstructing cancer or an esophageal mass, of course we know if you can't get in enough, you have to use parenteral nutrition. And this is one of the grade A recommendations of ESPN, of ASPEN, of many of our societies, right? And of course, it's critical to realize that there is no association of TPN with infection in 2023. We have 4 large randomized trials and thousands of patients in journals you've heard of, New England Journal, Lancet, JAMA, that it's just as safe to put TPN through a central line as it is saline through a central line. And so don't let anyone tell you we shouldn't start TPN because it might cause an infection. It does not. And our new ASPEN guidelines say that there is no difference between early enteral nutrition and early parenteral nutrition if you can't use enteral. So don't worry about using them interchangeably. Their risk is the same. And so we need to be starting early. If you have a big surgery or you have an open abdomen at the hospital I work at, we start TPN day 2 every time. Every time. We're doing research in that area too. And so again, there are now randomized trials that show not only is TPN not causing infection, but perhaps it's reducing infection. This is in JAMA surgery a few months ago. Patients having major surgery, abdominal surgery, randomized to supplemental parenteral nutrition or not at day 3 versus day 8. And they found significantly fewer infections in the patients who got early supplemental parenteral nutrition. in a large randomized trial. This is the highest impact surgery journal there is. So really strong trial, really critical data that, again, we should be using pre and earlier when we can't feed our patients. So again, in addition to the other things we need to do, immunonutrition is essential for all patients, not just malnourished patients, and should be considered for all patients. And this asks the question, could a simple nutrition drink reduce infection 40% in all of you and all of your patients? Is that possible? And we know that it is, and we know the mechanism, how it works. We know that a trauma from the surgeon or from getting hit by a car causes the depletion of arginine, which impairs our T cells. And this is something we have evolved for many, many years with as humans. This is induced by surgery and trauma. It has nothing to do with malnutrition. These myeloid-derived suppressor cells in our body, the cancer doctors discovered these, depletes arginine in our spleen and lymph nodes, and our body becomes immunosuppressed. And this has evolved since cavemen because we didn't want our immune system to kill us after 3 days if the tiger bit us, but there was no surgeon coming to save us. So we didn't need to live past 3 days, but now we do want our patients to live past 3 days. And so what's the data for this? Of course, we know the data is compelling. This was a meta-analysis we did a few years ago, showed in over 3,000 patients, 30 trials, 60% or 40% reductions in infections in patients who received this for 5 days before surgery or after surgery. And it reduces length of stay by 2 days. And this is in well-nourished patients and malnourished patients. And so you can see there's many, many studies that show this. Way too many to show, and some of them very high impact journals. And it works if you give it before surgery. It works if you give it during or before and after surgery, and it works if you give it only after surgery as well. It works in GI surgery patients, cardiothoracic surgery patients, ENT patients. So lots of groups of patients have been studied. And this has nothing to do with malnutrition. There are trials in big journals like Gastroenterology that show this works in well-nourished patients just as well. So again, this is not related to malnutrition. Everyone should get this. Again, this is pretty simple, right? We should be doing this. This is a no-brainer. But are we? Well, I can tell you in the US, when we survey practice, less than 1% of US patients are receiving this. Who gives this routinely in your hospitals right now? Raise your hand. Well, I don't see very many. Same in Brazil, about 1%. So we can be better. So should we cancel the gentleman's surgery? Elijah probably should not have surgery tomorrow, right? And give him pre-op nutrition for 1 to 4 weeks. Of course we should, but we didn't. This still happens all the time, that malnourished patients aren't getting what they need. So it's now the morning of surgery, and should he get a pre-op carb load? Of course, the recommendations say he should. And what's the data for that? Again, this is an important part of ERAS, the pre-op carb load on the morning of surgery and minimizing MPO times. So we recommend a pre-op carb load using maltodextran, not Gatorade, not orange juice. I'll tell you why. Maltodextran, complex carbohydrate the morning of surgery, and 2 the night before if you can do it, just like a marathon. And this comes from data in the Cochrane meta-analysis, very rigorous, that shows a 1.5 day reduction of stay from a drink that costs $4 US. This is $2,000 US of savings from something that costs $4. It also reduces pain, nausea, anxiety, thirst, and lots of things that make surgery miserable for the patient, I can tell you. And there's good data for that. So again, this needs to be a 12% carbohydrate that's low in osmolality, so it empties the stomach. The reason we feel good about, I'm an anesthesiologist also by training, we feel good about this because a low osmolality carbohydrate empties the stomach quickly. Other things do not. Sports drinks are simple sugars with a higher osmolality that don't empty the stomach quickly, and you could aspirate, and it'd be very hard to defend yourself because they don't empty the stomach as quickly. The other thing is, to work, this carb load has to be taken over 5 minutes. It cannot be sipped over 2 hours. You have to tell your patients they have to drink it quickly. That's how it defeats the insulin resistance. Franco Carli did great research that showed if you drink it over 5 minutes versus drinking it over an hour, there's a huge difference in the benefit of it. And so that's really critical. And so again, the maltodextran is really key. You don't want to use a simple sugar like orange juice or Gatorade. Can you give it in type 2 diabetics? So there's not a lot of data here, but we just recently published this. We reviewed all the data we could find, and we showed it didn't seem to have issues with gastric emptying in diabetics, type 2 diabetics. Carb loads seem to not raise the glucose too much in diabetics, who not type 1s, but type 2s. And it seemed to potentially reduce complications in diabetics. We routinely give it in our type 2 diabetics who are not insulin dependent. So you can do this, and we need more data here. So if you're looking for a research project, this is a good one. So again, this seems like a no-brainer. It costs $4. Definitely improves outcomes. The patient feels better because they did it. Not many people do it, and this patient didn't get it either. So this is something we can do better. So Elijah goes to surgery, and now it's the first day of, he's in the recovery room, first day of surgery. We recommend a high-protein diet be initiated, not clear liquids, a high-protein diet be initiated the day of surgery. Not clear liquids, not salt and sugar. Those aren't good for you. We did a meta-analysis on this with a group from New Zealand and Australia. And we found that compared to NPO or clear liquids, giving a protein-containing fluid in the first 2 days of surgery reduced mortality 70%. There's another study in one of the British journals that shows a 50% reduction in mortality. We're not the only ones to see this difference, but we're the first to look at protein specifically containing fluids. It also reduced complications of all kinds. And the patients didn't vomit more, they vomited less. And they didn't have adverse effects on their surgical anastomoses. Again, ERAS is really compelling, right? Ollie Lundquist looked at his first 900 cancer patients, and he looked at their survival 5 years later. And the patients that got more than 70% of the ERAS components had 70 or 42% lower mortality 5 years later. So what you do around the time of surgery for your patients reduces mortality years later. Of the two things that made the biggest difference, feeding on day one was the most important factor in ERAS, along with good fluid management in the operating room. So this was the most important facet in ERAS and changing mortality 5 years later. Again, do I have to tell you any more? So we should do this, but do we? We don't. We know that patients are routinely NPO more than 3 days. And when we survey practice, we found surgical patients are fed more poorly than any other patient in the hospital. Worse than the medicine patients, worse than anyone else. And GI surgery patients, who are almost all at the poorest. Again, we have to be better. So what happened to Elijah? He went to surgery, and again, he did pretty well for the first 3 days, and then he got rushed back to the OR. He had acute abdominal pain and rectal bleeding. He gets to the operating room in shock. He has a cardiac arrest on the table, gets CPR for 5 minutes, recovers. Remember, he's 90 years old almost. He comes back to the ICU where I took care of him. They found an anastomotic leak and they fixed it. So now he's back in the ICU with an open abdomen, 89 years old, very weak on the ventilator. And his nutrition status is not good. So the nurses begin to say to me, Dr. Wishmeyer, he can't survive this. We should stop. He's too old. He's too sick. He's going to die. We should withdraw care. We should let him die. But that's not what the patient wanted. And that's not what the family wanted. So his surgeon and I said, no, this patient wants to live. He wants to see his granddaughter. He's never met her. It's his only dream is to meet his granddaughter. And so what are we going to do about this? The family wants to keep going. The patient wants to keep going. So, and remember, he was very active for his age. He was fixing the roof of his church just a few days before. So we're going to fight for this patient, we decide as the physician team. And so what can we do for this patient? What are we going to do for this patient? And how are we going to make sure he's a survivor and not a victim like Joshua was? What can we do different that we didn't do for Joshua? How can we be better? So again, first we began to measure his muscle mass and we began to get a sense of where he was starting. And so we used BIA and we used muscle sound. Again, he had very little muscle. You can see this is the muscle sound measurement. This measures muscle glycogen as well. Lots of fat mass, even for a very thin man. Very little muscle in his leg. And so again, we need to really be aggressive here. So again, is he going to eat enough as he gets off the ventilator and he starts to be able to eat? We know patients don't eat enough on their own. They average about 700 calories. That's not enough to recover. So again, our recommendations say we have to reach a protein goal in these patients, and it's more important than calories. And so we recommend all patients get high protein ONS. And this was the strongest recommendation aside from screening of the committee, that all patients receive high protein ONS after surgery. And again, this is critical to outcome. We have lots of data to show this. This is just one of the studies that showed in colorectal surgery, giving high protein ONS for the first few days after surgery reduced length of stay by 4 days. 4 days, and this is in a very high impact factor journal. So this is very effective. Why do we use the high protein with HMB? This is the largest randomized trial I've seen looking at mortality of an oral nutrition supplement. A high protein ONS with HMB, you can give it as a pill or you can give it in the supplement, reduced hospital mortality by half at 90 days in hospitalized patients. 78 centers, 650 patients. Again, significant reductions in mortality at every time point measured. I actually was the reviewer for this paper. It's one of the best papers ever done in oral nutrition supplements. So this is an essential part of care to improve outcomes for our patients. So what can we do differently that we didn't do for Joshua to help Elijah get through this? And are there things we need to do that go beyond nutrition? Right? Is nutrition enough to win the war for our patients, especially a patient like this one? Because again, if you feed the patient well, you'll reduce, we've hypothesized, the muscle loss. But we've always said, and I've taught for 20 years, that you can't stop it, that you can't stop the muscle loss. Because we as humans aren't meant to survive this. We're not evolved as humans to survive these kinds of insults, right? This catabolism and hypermetabolism can last for months to years after a major insult like this. And so some people never get it back. So what can we learn from elite athletes to do better for our patients? Again, to look like this, you can't just eat right. He does more than eating to look like this, right? And so this is where anabolic steroids and supplements become essential. This is essential. Again, you shouldn't give this in the first few days of critical care. The body needs to be able to do the right catabolic things to survive for the first 3 or 4 days. But then I start checking, and I measure free testosterone. Total testosterone. I measure total testosterone in all my patients. And they're severely deficient, usually almost unmeasurable. Men and women, but men especially. And what they found is by giving back oxandrolone and testosterone in burn patients, which is standard of care in every part of the world, if I was in South Africa or India or even poor burn units, they all give oxandrolone. It improves survival. Any of you that work in a burn unit probably give this drug routinely. But the question that I always get is it safe? Does it increase the risk of heart attack? Does it increase clotting risk? Does it increase stroke risk? It does not. It does not. It reduces your risk of having a heart attack if you're deficient, and it reduces the stroke risk. So you should be repleting your patients who are deficient even if they're not sick like this. This was a 43,000 patient study in JAMA Internal Medicine, that looked at deficient men who got testosterone replaced versus not. The patients who had their testosterone replaced, 30% less strokes, 33% less heart attacks, less cardiovascular events overall, 43,000 patients. Even patients with coronary disease have less heart attacks and strokes in another study that was published. So again, this is something I'm routinely checking. You only need to check the total. It's very cheap, comes back in an hour in our hospital. They're almost all deficient. This is how you replete it. If you have oxandrolone, you're using oral. This is the dose in a 70-kilo adult. If they're smaller or older, give 5. We don't have oxandrolone because we're not a burn hospital. I use testosterone cypionate. 200 milligrams IMQ 2 weeks is a brilliant way to do this. If they're small, 150 is good. And ensure they get enough nutrition. And then I measure testosterone levels a week later if I'm giving an IM to be sure they're correcting to 400 or 500. So again, if you want to read more about this is a paper we published just recently on the different studies and different doses of this drug that's been used. So you can learn more about it if you want to read more about this. What about exercise? The last thing I'm going to tell you before I finish the stories is what about exercise, right? It's got to be important. And isn't it awful when this happens? I've had this happen many times. How is this guy running in front of me? So can we learn from our elite athletes how to help our patients exercise better? This is one of my research passions along with nutrition. And exercise before surgery can't look like this. It needs to look like this. This is what we do in our hospital for our patients, and I'll show you how we do it. This is cardiopulmonary exercise testing. This is what Olympians and professional football players and professional athletes do, right? It does all kinds of things. It gives you your VO2 peak, and it tells us all about your metabolism, and it tells about your fitness. And we can do it in lots of different ways I'll show you. So can we do this in old surgical patients or patients out of the ICU? It seems like that would be hard. It's not actually. This is a reality. This is John Whittle and Earl Mullinger. They do research with me. And we did a study in surgical patients, frail surgical patients like Elijah, looking at can we use high-intensity training to do this with them. And this is one of the patients we treated. Her name was Michelle. She was coming for bladder cancer. She could barely get out of her wheelchair and walk with a walker. And nobody would operate on her liver cancer because she was too frail. And so she finally came to us after being at 5 other universities. And so we took her into it, and we had her sit on a bike and ride the bike. We used their max heart rate on the VO2 peak that we get on the CPET test to create a HIIT training. We put a card on an exercise bike, and it takes them to a program. And then we give them high protein OS with HMB 2 times a day. In this patient, we put 1.5 kilograms of lean body mass on her legs in 4 weeks. The less fit you are, the more responsive to exercise you are. If you're really fit, it's much harder. If you're never exercised, it's much easier. And we increased her VO2 peak, her METs, exercise tolerance, by a whole MET in just 4 weeks. This is how potent it can be in a person who's not very fit. If she could maintain that the rest of her life, her lifetime mortality risk has just gone down 15%. This is what 4 weeks of exercise this way can do. Now, not everybody can do this. We can't do this in the hospital. So what about something we can do in the hospital? It can do this. You can do a step test. We validated it. We have a Bluetooth VO2 mask, and we have a large trial. The NIH funded $4 million, 4 centers for COVID patients after COVID. We do the step test in their ICU room. We get their VO2 peak and their heart rate. We send them home with an iPhone and an iWatch. They have a physical therapist that talks to them twice a week, and they do high-intensity training to a heart rate target 3 times a week at home. And this is what we've done it in our bone marrow transplant patients for over a year now. This is what the data looks like when they do it. They adhere to it. They exercise more days than we ask them, believe it or not. They can increase their VO2 peak 25% in 4 weeks. These are debilitated cancer patients. So we're doing this in COVID right now across 4 centers. Again, we can do this in anyone. This is what we do. We bring them back at 3 months and we retest them, and then we follow them. We look at their mitochondrial function. We do a lot of things. But the reality is, if we're going to optimize patients like Elijah, who's 90, or like anyone, we have to treat all 3 things. We need exercise, we need nutrition, and we need anabolic signal to give people back their quality of life. So what happened to Elijah? He had a cardiac arrest on the table at age 90, was on the ventilator with an open abdomen, but he wanted to fight, and his family did too. What did we do? Started high protein ONS. We gave him enough protein. We started testosterone. His testosterone was 5, I will tell you. We gave him creatine, just like the athletes take. We replaced his vitamin D. Vitamin D is essential to muscle function. And we made sure that it stayed corrected. And then we started him on exercise. If I can get this to change. He brought in his own weights, and we had exercise bands in the bed, and he did sit to stands, and he walked in the hallway. He was very good at participating in physical therapy. And 28 days later, after a 90-year-old had a cardiac, or 89-year-old had a cardiac arrest, he walked out of the hospital on his 90th birthday. Yes, so this is possible. That's him. He gave me permission to use this picture. That's him laying in bed with his weights in his hand. He was committed. So why is it that I, as an ICU doctor and an ICU physician and an anesthesiologist, care so much about nutrition? And why do I hope and know you all do too? And why am I so glad all of you in Brazil do too? Well, how many of you have had surgery? And then I'm going to be done. How many of you have had surgery? Raise your hand. So if you lived in the United States, all of you would raise your hand. The average US citizen will have 9.2 surgeries in their lifetime. Some of these are cosmetic, but nonetheless, 9.2 surgeries. So someday this will be you, or someone you care about for sure, probably more than once. And for better or for worse, maybe I've used up some of your surgeries already, because this was me at age 15. Just like Joshua, the reason Joshua means so much to me is I had IBD, ulcerative colitis, at age 15. This is me on TPN. TPN and Nutrology and nutritionists and dietitians and pharmacists saved my life. I was on TPN for a year, was in the hospital for a year. My colon perforated, I got septic, had my colon taken, was on TPN for most of that time, and ultimately have had an ostomy ever since. Now, of course, they tell you that you're cured of your IBD when you have your colon out, but what they don't tell you is you get adhesions and you get obstructions. And so I've had 27 surgeries, abdominal surgeries myself, and I have 140 centimeters of small bowel total right now standing in front of you. So I'm functionally short gut. But I do okay. This was me in 2014 with my middle son visiting my grandfather, best shape of my life, in July. A month later, I ate some quinoa. Don't ever eat quinoa if you've had surgery, because this happened. You know what that is? Small bowel obstruction. This was me in my own emergency room where I worked with a lactate of 10, in shock, being rushed to the operating room with an acute abdomen. Being operated on by my own surgeons I trained. It was terrifying. Ultimately, I was in surgery for 9 hours, because you can imagine I have not a very fun abdomen to operate on. I have many adhesions like concrete. And ultimately, in 2014, I was in the hospital for 23 days on TPN. I wrote my own prescription, 25 kcals per kilo and 1.5 grams protein seemed like enough. I'm well-nourished, seemed fit. Despite being on TPN, I went from looking like this to looking like this in 17 days. I lost 20 kilos in 17 days on TPN. And I couldn't walk down the hospital hallway without being short of breath within a week. And I was very fit before that. And so I thought, no one is immune to this. No one can be spared, and there's nothing much we can do. I couldn't even pick up my youngest son at Christmas. 5 months later, I was too weak. I was too weak to pick him up. It took a long time to recover. So nutrition optimization is part of my everyday life. It took 2 years to recover from that surgery in 2014, and 4,000 to 5,000 calories a day. I want you to remember that number, and 2 grams per kilo per day of protein. I like to show pictures of my ostomy because I have a lot of patients that get ostomies and think their life is over, that no one will ever like them again or they'll never be active again. I say there's nothing you could do before that you can't do with an ostomy. I was surfing in Hawaii before this picture was taken. You can do anything with an ostomy, and I always hope that gives them hope. And of course, exercise was essential too. So patient recovery is a personal passion of mine because I knew in 2014 I would be in the operating room again. I always tell my residents that midnight phone call, the patient with a bad abdomen you don't want to go see, yeah, that might be me. And in February of last year, it was me. My bowel obstructions came back last spring, and they were coming too often and threatening my life, and my kidney was getting obstructed. I was a lot of issues. And so I decided that month, last year, about this time last year, that I was going to have an elective surgery, which seemed insane, but I just couldn't live this way anymore. We were afraid to leave the country. We were afraid to leave our hometown because I would get sick. And so on April 20th of last year, I underwent a major operation. And so I thought, oh my gosh, this is going to be a big operation. I'm going to lose more strength, more weight. It's going to take years to recover. This is going to be terrible. And so the key, I thought I need to do things differently. And so again, recovering from surgery needs to start long before the day of surgery. And so what can I do different this time to recover from surgery? And I realized I had to do things differently. So what did I do? I did pre-op metabolic cart testing to find out what my catabolic or my calorie needs actually were. We'll talk about that in a minute. 3,000 was the number if you didn't see that. This is what I was pre-op. That's my basal resting energy expenditure. We did muscle mass testing, and I did my own. This is what it looks like. This is what step testing looks like when we do it with our patients. I did it too. This is how we get our VO2 peaks for our exercise prescriptions. And this is how we target exercise. These are all the supplements I take every day. If you were in my hotel room down the street, you'd see a separate suitcase with all this stuff in it. I take this every day. Every day. And I added a few things before surgery. I discovered my testosterone level was low 2 years ago when I broke my arm skiing with my son because I don't reabsorb cholesterol because I'm short gut. And so I've been taking it for about 2 years at this point. That'll become important. So I went to surgery on April 20th of last year, 13-hour surgery by our intestinal transplant surgeon, who's the one who did it. She took 20 centimeters more bowel out, and she did a cholecystectomy. This is me in my surgical ICU the night I had surgery last April. Rehab has to start the day after. We tell our patients you have to walk within 12 hours of surgery. You can, you should, and they need to do this. This is me walking in the ICU right after my operation. And we started TPN immediately because she knew my bowel was a mess for mashing on it for 13 hours. And so that's me on TPN wandering the ICU hallways. Unfortunately, 2 days later, I awoke at 2 in the morning and my gown was soaked and I had a fever. And I looked down and there was stool pouring out of my abdominal incision. And I was getting septic and going into shock. Was rushed back to the operating room myself with peritonitis. My transplant surgeon operated on me 2 more times over the next 3 days for that same leak. She couldn't fix it, and I developed a fistula. I developed a nasty fistula, which was my worst nightmare. We've all taken care of fistula patients that don't get better for years. And I'm like, oh my God, that's gonna be me. And so I ended up in my own ICU, intubated now, being cared for by my own residents and my own physician colleagues on the ventilator in the ICU, very sick with septic shock. And of course, now I've got a GI fistula. And so I thought for sure I'm going to lose a lot of weight now. I'm gonna be weak for years. I'm gonna lose all kinds of muscle. This is the sickest I've ever been in my life. Maybe not. Maybe we can do this differently. Maybe with personalized targeting of nutrition and knowing what we need to do, it can be different. So again, TPN started early, guided by endocalorimetry. 3,000 kcals per day was my resting. Plus I was active, I was walking, I was doing physical therapy. So I was getting 4,000 calories a day on my TPN. 4,000, who would write that? Not me, not if I didn't know the number, but I had the number. This is me walking with my TPN at 4,000 calories a day with a good lipid, of course, that makes a difference. We'll talk about that tomorrow. I was discharged home on TPN. This is me at home on TPN for months. This is me laying on the couch with my TPN. This is my dog, who is my coach, helping me with my TPN. Lipid choice matters, of course. It's hard to pull off 4,000 calories a day with a bad lipid. No LFT abnormalities that whole 3-month period. And I had to start exercising right away with my PICC line, my open abdomen, my fistula drain. This is me on my exercise bike lifting weights. My surgeon said I can only lift 5 kilos, so those are small weights. But this is what it looks like. Anybody can exercise after surgery, I would advocate.
The next time you feel like you can't work out, what do you think of this guy?
It's my wife, trying to be encouraging. I lost a total of less than 5 kilos all through that ICU stay. 5 kilos. Remember, I told you I lost 20 kilos, not in the ICU last time, on TPN. I only lost 5, and I was back to my pre-op weight within 3 weeks. My face never got thinner. My strength never seemed to go away. And so 8 weeks later, I asked my surgeon, when she said, pick up more weight, can I start dancing with my wife again? Because we have a competition in 2 weeks. And can I lift my wife over my head? She weighs more than 5 kilos, but don't tell her I said that. And she said, I don't know, do you think you can pick her up? Do you think you're strong enough? And I said, I think I'm strong enough. And so 8 weeks later, we danced. This is me 8 weeks later. We danced competitively 8 weeks after my last operation. So again, things turned out differently this time. So losing strength, losing muscle mass, and losing weight is not mandatory. I've taught that for 20 years that it is. It's not. This can be different for all of our patients. That we can do this differently. We can personalize nutrition. We can target our patients' needs. We can use the right anabolic agents. And they don't have to end up like Joshua did. These are all the things I take today. This is what's in my hotel room right now. Every day I take this, because you never know, I might have surgery tomorrow in this hospital. You never know. And so again, surgical recovery has to be before the day of admission and carry long afterwards. And this is something we need to be focused on from the minute the patient goes to surgery clinic. Nutrition optimization matters. I didn't lose muscle. I didn't lose my quality of life. I didn't lose my regular way of life. And it was okay. My pre-op preparation is part of my everyday life, and we need to teach our patients to do the same. So again, this needs to be something our patients learn from us. And who's going to teach them? Who's going to teach them to do this? You are. You're the people that care enough to be here right now, this late in the evening, to hear this. You're the ones who can save and change your patients' lives. So again, in summary, a major surgery is a chance to change a patient's life forever. They will treat their diabetes, they will stop smoking, they will exercise, and they will eat right for the first time in their lives. And most of the ones that start doing this want to keep doing it, so you can change your patients' lives. This is a huge opportunity for all of us. And again, we need to train them like we train people for running a marathon. It's the marathon of their lives, and we need to be better than we have been to do it. These are the simple things that I told you before that we can all do to improve our patients' surgical outcomes. These are the things we do that in our pathways to get them well nourished before their operation. And if you want to read more about this, this is a paper we published, and it's open access, it's free. This is how we started our nutrition clinic for surgical patients. We have posters in this paper that you can use and put in your clinics. We have all our pathways, everything's in this paper. And so again, this is a chance for us to change the world and never have a patient go to the operating room without having nutrition therapy be part of their care. And I dream of a day when all our patients will be able to be best ready and best recovered from surgery with nutrition and exercise. Because the reality is, if we had done this before, Joshua would still be alive and with us today. And so that's what I think we need to do, and I'll let the people who do awesome better than me take us out. Thank you. Thank you, guys. Thank you.
Well, next time I'll have surgery, I'll have it done you guys style.
I'll have my skateboard ready.
I also just want to leave all of you that are passionate about nutrition. If you want to keep learning from the internationally best experts, we have started an online international clinical nutrition fellowship. The very best people from around the world teach online courses, and you get to interact with them in a Zoom meeting. You get to know them. Which running right now. We have numerous people from around the world interacting in this. We would love to have all of you join. The link is here. You can still join some of the modules. There's still some spots left, but I look forward to hopefully seeing all of you in these classes in the future. And with that, please share this data and this knowledge on Twitter and Instagram. Follow me if you don't. We have a lot of, here, I'll put that back up. We have a lot of new papers that we share all the time on Instagram and on Twitter. So follow and share this information. And I'm happy to send these slides to anyone if you want to email me. Thank you.